Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today, under Unit 18, Therapy of Infectious and Parasitic Diseases, we're talking specifically on Chapter 73, sulfonamides as well as trimethoprim. So, we'll jump right in. Sulfonamides and trimethoprim. The sulfonamides and trimethoprim are broad-spectrum antimicrobials that have closely related mechanisms. They all disrupt the synthesis of tetrahydrofolic acid, a derivative of folic acid and folate. In approaching these drugs, we begin with sulfonamides, followed by trimethoprim, and then conclude with the combination of trimethoprim sulfamethoxazole, an important fixed-dose combination. So, sulfonamides. Sulfonamides were the first drugs available for systemic treatment of bacterial infections. After their introduction in the 1930s, their use produced a sharp decline in morbidity and mortality from susceptible infections. With the advent of penicillin and newer antimicrobial drugs, use of sulfonamides has greatly been declined. Nonetheless, sulfonamides still have important uses, primarily against urinary tract infections. With the introduction of trimethoprim sulfamethoxazole in the 1970s, indications for sulfonamides expanded. So let's touch base on their basic pharmacology. Similarities among the sulfonamides are more striking than the differences. Accordingly, rather than focusing on representing a prototype, we will discuss sulfonamides as a group. So here we can take a quick peek at its chemistry. The general structural formula for sulfonamides is shown in the following figure. Sulfonamides are structural analogs of para-aminobenzoic acid. The antimicrobial actions of sulfonamides are based on this similarity. So here you're taking a look at the structural relationship between sulfonamides, the para-aminobenzoic acid, and folic acid. Individual sulfonamides vary greatly with respect to solubility in water. Older sulfonamides had low solubility, therefore they often crystallized out in the urine, causing injury to the kidneys. The sulfonamides in current use are much more water soluble, and therefore that risk for renal damage is considered low. So how do they work? Sulfonamides are usually bacteriostatic. Accordingly, adequate host defenses are essential for elimination of infection. Sulfonamides suppress bacterial growth by inhibiting synthesis of tetrahydrofolate, a derivative of folic acid. Folate is required by all cells to make DNA, RNA, and its proteins. The steps in folate synthesis are shown in Figure 73.2. Sulfonamides block the step in which PABA is combined with piperidine to form a dihydropiperoic acid. Because of their structural similarities to PABA, sulfonamides act as competitive inhibitors of this reaction. So here you're taking a look at sites of action of sulfonamides and trimethoprim. It's a good spot to hit pause if you're unfamiliar with how it works. If all cells therefore require folate, why don't sulfonamides harm us? Well, the answer lies in how bacteria and mammalian cells acquire folic acid. Bacteria are unable to take up folate from their environment, so they must synthesize folic acid from precursors. In contrast to bacteria, mammalian cells do not manufacture their own folate. Rather, they simply take up folic acid obtained from their diet, using a specialized transport system for uptake. Because mammalian cells use preformed folic acid rather than synthesizing it, sulfonamides are harmless to us. Which brings us to our microbial resistance. Many bacterial species have developed resistance to sulfonamides. Resistance is especially high among the gonococci, meningococci, streptococci, and shigella. Resistance may be acquired by spontaneous mutation or by transfer of plasmids that code for antibiotic resistance, again that R factor. Principal resistance mechanisms are reduced sulfonamide uptake, synthesis of PABA in amounts sufficient to overcome sulfonamide-mediated inhibition of dihydropeptidoglycan synthetase, and alteration in structure of dihydropeptidoglycan synthetase such that binding inhibition by sulfonamides is reduced. Its antimicrobial spectrum. Sulfonamides are active against broad spectrum of microbes. Susceptible organisms include gram-positive cocci, gram-negative bacilli, Listeria monocytogenes, actinomycetes, chlamydia, some protozoa, and 2 fungi, Pneumocystis jirovecii and Paracoccidioides brasiliensis. Its therapeutic uses, therefore, although the sulfonamides were once employed widely, their application are now limited. Two factors explain why: the introduction of bactericidal antibiotics that are less toxic than the sulfonamides, and two, development of sulfonamide resistance. Today, UTI is the principal indication for these drugs. So that brings us to our urinary tract infections. Sulfonamides are often preferred drugs for acute UTIs. About 90% of these infections are due to E. coli, a bacterium that is usually sulfonamide sensitive. Of the sulfonamides available, sulfamethoxazole is generally favored. It has a good solubility in urine and achieves effective concentrations within the urinary tract. UTIs are discussed further in Chapter 74. Other uses. Sulfonamides are useful drugs for nocardiosis, Listeria species infections, and infections with P. jirovecii. In addition, sulfonamides are alternatives to doxycycline and erythromycin for infections caused by C. trichomatis. Sulfonamides are used in conjunction with pyrimethamine to treat 2 protozoal infections, toxoplasmosis and malaria, caused by chloroquine-resistant Plasmodium falciparum. Topical sulfonamides are used to treat superficial infections of the eyes and to suppress bacterial colonization in burn patients. One sulfonamide, sulfasalazine, is used to treat ulcerative colitis. However, benefits in this disorder do not result from inhibiting microbial growth. Ulcerative colitis is discussed in further detail in Chapter 64. So, its pharmacokinetics. Absorption. Sulfonamides are well absorbed after an oral administration. When applied topically to the skin or mucous membranes, these drugs may be absorbed in amounts sufficient to cause systemic effects. Its distribution. Sulfonamides are well distributed throughout all tissues. Concentrations in pleural, peritoneal, ocular, and similar body fluids may be as much as 80% of the concentration in blood. Sulfonamides readily cross the placenta, and levels achieved in the fetus are sufficient to produce antimicrobial effects and toxicity. Its metabolism. Sulfonamides are metabolized in the liver, principally by acetylation. Acetylated derivatives lack antimicrobial activity but are just as toxic as the parent compounds. Acetylation may decrease sulfonamide solubility, thereby increasing the risk for renal damage from crystal formation. Its excretion. Sulfonamides are excreted primarily by the kidneys. Therefore, the rate of renal excretion is the principal determinant of their half-life. Adverse effects. Sulfonamides can cause multiple adverse effects. Prominent among these are hypersensitive reactions, blood dyscrasias, and kernicatures, which occur in newborns. Renal damage from crystalluria was a problem with the older sulfonamides, but is less common with sulfonamides used today. So, let's touch up on some hypersensitivity reactions then. Sulfonamides can induce a variety of hypersensitivity reactions, which are seen in about 3% of patients. Mild reactions, including a rash, drug fever, and photosensitivity, are relatively common. To minimize photosensitivity reactions, patients should avoid prolonged exposure to sunlight, wear protective clothing, and apply sunscreen to the exposed skin. Which brings us to a section here for patient education on sulfonamides. It's a good spot to hit pause so you can read over them, but the big ones being that make sure to take the medication as instructed for its full course, that patients should drink at least 8 to 10 glasses of water and or other non-caffeinated fluids per day. Again, wear protective clothing and do not get into tanning beds because of the ultraviolet rays. And then finally, instruct patients to observe for alterations that may indicate hypersensitivity, such as a rash. Hypersensitivity reactions are especially frequent with topical sulfonamides, so as a result, these preparations are no longer employed routinely. Rather, they are usually reserved for ophthalmic infections, burns, and bacterial vaginosis caused by Gardnerella vaginalis and a mixed population of anaerobic bacteria. The most hypersensitivity response to sulfonamides is a Stevens-Johnson syndrome, which is a rare reaction with a mortality rate of about 25%. Symptoms include a widespread lesion of the skin and mucous membranes, combined with fever, malaise, and toxemia. The reaction is most likely to occur with long-acting sulfonamides, which are now banned in the US. Short-acting sulfonamides may also induce the syndrome, but the incidence is considered low. To minimize the risk for severe reactions, sulfonamides should be discontinued immediately if skin rash of any sort is observed. In addition, sulfonamides should not be given to patients with a history of hypersensitivity to chemically related drugs, including thiazide diuretics, loop diuretics, and sulfonylurea type oral hypoglycemics, although the risk for cross-reactivity with these agents is considered low. Its hematologic effects. Sulfonamides can cause hemolytic anemia in patients with a glucose 6-phosphate dehydrogenase deficiency. This inherited trait is most common among Blacks and people of the Mediterranean origin. Rarely, hemolysis occurs in the absence of G6PD deficiency. Rituximab can produce a fever, pallor, and jaundice. Patients should be observed for these signs. In addition to hemolytic anemia, sulfonamides can cause agranulocytosis, leukopenia, thrombocytopenia, and very rarely, aplastic anemia. When sulfonamides are used for a long time, periodic blood tests ought to be obtained. Kernicterus is a disorder in newborns caused by the deposition of bilirubin in the brain. Bilirubin is neurotoxic and can cause severe neurologic deficits and even death. Under normal conditions, infants are not vulnerable to kernicterus. Any bilirubin present in their blood is tightly bound to plasma proteins and therefore is not free to enter the central nervous system. Sulfonamides promote kernicterus by displacing bilirubin from plasma proteins. Because the blood-brain barrier in infants is still poorly developed, the newly freed bilirubin has easy access to sites within the brain. Because of the risk for kernicterus, sulfonamides should not be administered to infants younger than 2 months. And in addition, sulfonamides should not be given to a pregnant patient after 32 weeks of gestation or to those who are actively breastfeeding. Which brings us to our patient-centered care across the lifespan. A good spot to hit pause so you can read up on sulfonamides and trimethoprim. So, renal damage from crystal urea. Because of their low solubility, the older sulfonamides tended to come out of solution in the urine, forming crystalline aggregates in the kidneys, ureters, and bladder. These aggregates caused irritation and obstruction, sometimes resulting in anuria and even death. Renal damage is uncommon with today's sulfonamides, owing to their increased water solubility. To minimize the risk for renal damage, adults should maintain a daily urine output of at least 1200 ml. This can be accomplished by consuming between 8 to 10 glasses of water each day. Because the solubility of sulfonamides is highest at elevated pH, alkalinization of the urine can further decrease the chance of crystalluria. Drug interactions. Metabolism-related interactions. Sulfonamides can intensify the effects of Coumadin, phenytoin, and sulfonylurea-type oral hypoglycemics, the principal mechanism of inhibition of hepatic metabolism. When combined with sulfonamides, these drugs may require a reduction in dosage in order to help prevent toxicity. Cross-hypersensitivity. There is a concern that people who are hypersensitive to sulfonamide antibiotics may be cross-hypersensitive to other drugs that contain sulfonamide moiety, such as your thiazide diuretics, loop diuretics, sulfonylurea-type oral hypoglycemics. However, there are no good data to show that such cross-hypersensitivity actually exists. In fact, clinical experience has shown that patients with a documented allergy to sulfonamide antibiotics have taken other sulfonamide drugs without any type of incidence whatsoever. Still, until more is known regarding that cross-hypersensitivity, it's best to avoid taking chances unless the benefit of giving the drug are greater than the risk. So, are sulfonamide preparations? Sulfonamides again fall into two major categories: systemic sulfonamides and topical sulfonamides. The systemic agents are used more often. So, touching on systemic sulfonamides. There are two groups of systemic sulfonamides, short-acting and intermediate-acting. These differ primarily with regard to the dosing interval, which is much shorter for the short-acting drugs. Speaking on sulfamethoxazole, which is the only intermediate-acting sulfonamide available, the risk for renal damage from crystalluria can be reduced by maintaining adequate hydration. Sulfamethoxazole is not available for use by itself, but is available in a combination with trimethoprim. Sulfadiazine. Sulfadiazine is a short-acting sulfonamide. Accordingly, if renal damage is to be avoided, high urine flow must be maintained. Sulfadiazine crosses the blood-brain barrier with ease, so it is best sulfonamide for prophylaxis of meningitis. When combined with pyrimethamine, sulfadiazine is useful against toxoplasmosis. Topical sulfonamides. Topical sulfonamides have been associated with a high incidence of hypersensitivity and are not used routinely. The preparations discussed here have proven utility and relative low incidence of hypersensitivity. Sulfacetamide. Sulfacetamide is widely used for superficial infections of the eyes, especially for the treatment of conjunctivitis or corneal ulcers. The drug may cause blurred vision, sensitivity to bright light, headaches, brow aches, and local irritation. However, hypersensitivity is considered rare, but severe reactions have occurred. Accordingly, sulfacetamide should not be used by a patient with a history of severe hypersensitivity to sulfonamides, sulfonylureases, or thiazide or loop diuretics. Sulfacetamide is available as a 10% solution for the application to the eyes. In addition to its ophthalmologic use, topical sulfacetamide is used for dermatologic disorders. The drug is available as a 10% solution in lotions, gels, washes, and shampoos for treating seborrheic dermatitis, acne vulgaris, and bacterial infections of the skin. Which now brings us to silver sulfadiazine and mafenamide. These sulfonamides are employed to suppress bacterial colonization in a patient with a second or third degree burn. Mafenamide acts by the same mechanism as other sulfonamides. In contrast, antibacterial effects of silver sulfadiazine is due primarily to the release of free silver, not to the sulfonamide portion of the molecule. Local application of mafenamide is frequently painful, but application of silver sulfadiazine is usually pain-free. After application, both agents can be absorbed in amounts sufficient to produce a systemic effect. Mafenide, but not silver sulfadiazine, is metabolized to a compound that can suppress renal excretion of acid, causing acidosis. Accordingly, patients receiving mafenide should be monitored for acid-base status. If acidosis becomes severe, mafenide needs to be discontinued for 1 to 2 days. Silver sulfadiazine can cause a blue, green, or gray skin discoloration, so facial application needs to be avoided. A Cochrane review questioned the ability of silver sulfadiazine to promote healing, but noted that the quality research studies were still lacking. Which now brings us to trimethoprim. Like the sulfonamides, trimethoprim, or primusol, suppresses the synthesis of tetrahydrofolic acid. Trimethoprim is active against a broad spectrum of microbes. So how does it work? Well, trimethoprim inhibits dihydrofolate reductase, the enzyme that converts dihydrofolic acid to its active form, tetrahydrofolic acid. Thus, like the sulfonamides, trimethoprim suppresses bacterial synthesis of DNA, RNA, and its proteins. Depending on the conditions at the site of infection, trimethoprim may be bactericidal or bacteriostatic. Although mammalian cells also contain dihydrofolate reductase, trimethoprim is selectively toxic to bacteria because bacterial dihydrofolate reductase differs in structure from mammalian dihydrofolate reductase. As a result, trimethoprim inhibits the bacterial enzyme at concentrations about 40,000 times lower than those required to inhibit the mammalian enzyme. This also suppresses the bacterial growth with doses that have essentially no effect on the host. Which brings us to the microbial resistance. Bacteria acquire resistance to trimethoprim in 3 ways: synthesizing increased amounts of dihydrofolate reductase, producing an altered dihydrofolate reductase that has a low affinity to trimethoprim, and reducing cellular permeability to trimethoprim. Resistance has resulted from spontaneous mutation and from a transfer of R factors. In the US, bacterial resistance is considered uncommon. Its antimicrobial spectrum, therefore. Trimethoprim is active against most enteric gram-negative bacilli of clinical importance, which includes E. coli, Klebsiella pneumoniae, Proteus mirabilis, Serratia marcescens, and Salmonella and Shigella species. The drug is also active against some gram-positive bacilli, as well as some pathogenic protozoa, including one fungus. So, its therapeutic use. Trimethoprim is approved only for the initial therapy of acute, uncomplicated UTIs due to susceptible organisms. When combined with sulfamethoxazole, trimethoprim has considerably more applications, which will be discussed later. So there is a section for patient education on trimethoprim. Make sure you want to inform patients about early signs of blood dyscrasias. Its pharmacokinetics. Trimethoprim is absorbed rapidly and completely from the GI tract. The drug is lipid-soluble and therefore undergoes wide distribution to body fluids and tissues. Trimethoprim readily crosses the placenta. Most of an administered dose is excreted unchanged in the urine. Therefore, in the presence of renal impairment, the drug's half-life starts to become prolonged. The concentration of trimethoprim achieved in urine is considerably higher than the concentration in the blood. So, its adverse effects and interactions. Trimethoprim is generally well tolerated. The most frequent adverse effects are itching and a rash. However, there are some GI reactions that occur occasionally. So, speaking specifically then on hematologic effects. Because mammalian dihydrofolate reductase is relatively insensitive to trimethoprim, toxicities related to the impaired tetrahydrofolate production are considered rare. These rare effects, however, include megaloblastic anemia, thrombocytopenia, and neutropenia, which occur only in individuals with a pre-existing folic acid deficiency. Accordingly, caution is needed when administering trimethoprim to a patient whom folate deficiencies may already likely be occurring, such as your alcoholics, pregnant women, or debilitated patients. If early signs of bone marrow suppression occur, complete blood counts should be performed. If a significant reduction in blood cell count is observed, trimethoprim should be discontinued. Administering a leucovorin will restore normal hematopoiesis. Adverse effects in regards to hyperkalemia. Trimethoprim suppresses renal excretion of potassium and can thereby promote hyperkalemia. Patients at greatest risk are those taking high doses, those with renal impairment, and those taking other drugs that can elevate potassium, including your ACE inhibitors, angiotensin receptor blockers or ARBs, potassium-sparing diuretics, aldosterone antagonists, and potassium supplements. Patients older than 65 years of age who are taking an ACE inhibitor or an ARB are at especially high risk. Risk can be reduced by checking serum potassium, preferably 4 days after starting treatment. Effects in pregnancy and lactation. Large doses of trimethoprim have caused fetal malformation in animals. To date, developmental abnormalities have not been observed in humans. Nonetheless, because trimethoprim readily crosses the placenta, prudence dictates avoiding routine use during pregnancy. The risk for exacerbating pregnancy-related folate deficiency is an additional reason to avoid the drug. Trimethoprim is excreted in breast milk and may interfere with folic acid utilization by the nursing infant. Administer with caution to a woman who are breastfeeding. Which brings us now to our combo drug, trimethoprim sulfamethoxazole. Trimethoprim TMP and sulfamethoxazole SMZ are marketed together in a fixed-dose combo drug. This combination is a powerful antimicrobial preparation whose components act in concert to inhibit sequential steps in tetrahydrofolic acid synthesis. Trade names for the TMP SMC include Bactrim and Septra. In many countries, the combination is generally known as cotrimethazole. So how does it work? Its mechanism of action. The antimicrobial effect of TMP-SMZ results from inhibiting consecutive steps in the synthesis of the tetrahydrofolic acid. SMC acts first to inhibit the incorporation of PABA into folic acid. TMP then inhibits dihydrofolate reductase, the enzyme that converts dihydrofolic acid into tetrahydrofolate. So as a result, the ability of the target organism to make nucleic acids and proteins is greatly suppressed. By inhibiting the two reactions required for synthesis of tetrahydrofolate, TMP and SMC potentiate each other's effects. That is, the antimicrobial effects of the combination is more powerful than the sum of the effects of TMP alone plus SMC alone. The combo drug is selectively toxic to microbes because mammalian cells use preformed folic acid and therefore are not affected by SMC, and dihydrofolate reductases of mammalian cells are relatively insensitive to the inhibition by TMP. Microbial resistances, therefore. Resistance to TMP-SMC is less than to either drug alone. This is logical in that the chances of an organism acquiring resistance to both drugs are less than its chances of developing resistance to just one or the other. Its antimicrobial spectrum. TMP-SMC is active against a wide range of gram-positive and gram-negative bacteria. This should be no surprise in that TMP and SMC by themselves are broad-spectrum antimicrobial drugs. About 80% of urinary tract pathogens are susceptible. Specific bacteria against TMP-SMC is consistently effective, including E. coli, P. mirabilis, L. monocytogenes, S. aureus, C. trachomatis, Salmonella typhi, Shigella species, Vibrio cholera, Haemophilus influenza, and Yersinia pestis. TMP-SMZ is also active against Nocardia species, certain protozoa, and 2 fungi. So, its therapeutic use. TMP-SMC is a preferred or alternative medication for a variety of infectious diseases. This combo drug is especially valuable in UTIs, otitis media, bronchitis, shigellosis, and pneumonia that is caused by P. giovecii. Urinary tract infections. TMP-SMC is indicated for the treatment of uncomplicated UTIs caused by susceptible strains of E. coli, Klebsiella, and Enterobacter species. P. mirabilis, Proteus vulgaris, and Morganella morgani. The combination is particularly useful for chronic and recurrent infections. Pneumocystis pneumonia, or PCP. TMP-SMC is the treatment of choice for PCP in an infection caused by P. giovecii, formerly thought to be Pneumocystis carinii. P. giovecii is an opportunistic fungus that thrives in immunocompromised hosts. When given to an AIDS patient, TMP-SMC produces a high incidence of adverse effects. Gastrointestinal infections. TMP-SMC is a drug of choice for infections caused by several gram-negative bacilli, again including that Yersinia enterocolicia and Aeromonas species. In addition, the combination is a preferred treatment for shigellosis caused by susceptible strains of Shigella flexneri and S. soni. Other infections. TMP-SMC can be used for otitis media and acute exacerbations of chronic bronchitis. When these infections are due to susceptible strains of H. influenzae or Streptococcus pneumoniae, the preparation is also useful against urethritis and pharyngeal infections caused by penicillinase-producing Neisseria gonorrhea. Other infections that can be treated with TMP-SMC include our whooping cough, nocardiosis, brucellosis, melioidosis, listeriosis, and cancroid. So, its pharmacokinetics, absorption and distribution. TMP-SMC may be administered orally or via an IV infusion. Both components of the TMP-SMC are well distributed throughout the body. Therapeutic concentrations are achieved in tissues and body fluids, and both TMP and SMC readily cross the placenta and both enter the breast milk. Our plasma drug levels. Optimal antibacterial effects are produced when the ratio of TMP to SMC is 1 to 20. To achieve this ratio in plasma, TMP and SMC must be administered in a ratio of 1 to 5. Therefore, standard tablets containing 80 mg of TMP and 100 mg of SMC. Because the plasma half-lives of TMP and SMC are similar, about 10 hours, levels of both drugs decline in parallel, and the 1 to 20 ratio is maintained as the drugs are eliminated. Elimination. Both TMP and SMC are excreted primarily by the kidneys. About 70% of urinary SMC is present as inactive metabolites. In contrast, TMP undergoes little metabolism before excretion. Both agents are concentrated in the urine. Therefore, levels of active drug are higher in the urine than in plasma, despite some conversion to inactive products. Adverse effects. TMP-SMC is generally well tolerated. Toxicity from routine use is rare. The most common adverse effects are nausea, vomiting, and rashes. However, although infrequent, all of the serious toxicities associated with sulfonamides alone and trimethoprim alone can occur with the combo drug. So, like sulfonamides, the combination can cause hypersensitivity reactions, blood dyscrasias, kernicterus in neonates, renal damage, megaloblastic anemia, hyperkalemia, and birth defects. TMP-SMC may also cause adverse CNS effects, so your headaches, depressions, and hallucinations. Patients who are suffering from AIDS are unusually susceptible to TMP-SMC toxicity. In this group, the incidence of adverse effects of rashes, recurrent fevers, and leukopenia was as high as 55%. Several measures can reduce the incidence and severity of adverse effects. Crystalluria can be avoided by maintaining adequate hydration. Periodic blood tests permit early detection of hematologic disorders. To avoid kernicterus, TMP-SMC should be withheld, again, from pregnant patients, near-term, nursing moms, and infants younger than 2 months. To avoid possible birth defects, TMP-SMC should be withheld during the first trimester. The risk for megaloblastic anemia can be reduced again by withholding sulfonamides from individuals likely to be folate deficient. Hypersensitivity reactions can be minimized by avoiding TMP-SMC in patients with a history of hypersensitivity to sulfonamides or to chemically related drugs. Again, those include our thiazide diuretics, loop diuretics, and the sulfonylurea type oral hypoglycemics. Injury from hyperkalemia can be reduced again by checking our serum potassium and by exercising caution in patients taking other drugs that can elevate potassium. Other drug interactions. Interactions of TMP-SMZ with other drugs are due primarily to the presence of SMC. Consequentially, like sulfonamides used alone, SMC in the combination can intensify the effects of Coumadin, dilantin, and sulfonylurea type oral hypoglycemics, such as glipizide. Accordingly, when these drugs are combined with TMP-SMC, a reduction in their dose may be required. TMP-SMC may also intensify bone marrow suppression in patients who are receiving methotrexate. So, as noted, drugs that raise potassium levels can increase the risk for hyperkalemia from TMP. Prescribing and monitoring considerations for sulfonamides. Sulfonamide systemics. The nursing implications summarized here apply only to systemic sulfonamides. Implications specific to topical sulfonamides are not summarized. So, your dosage and administration are provided in the following table. An outstanding spot to hit pause so you can take a look at different dosages. Speaking now on assessment, its therapeutic goal. Sulfonamides are used primarily for UTIs caused by E. coli and other susceptible organisms. Additional indications for TMP-SMC include shigellosis and PCP. Identifying a high-risk patient. Sulfonamides are contraindicated for nursing mothers, pregnant women in the first trimester or near term, and again, those infants younger than 2 months. In addition, sulfonamides are contraindicated for patients with a history of severe hypersensitivity to sulfonamides and chemically related drugs. Again, our thiazide diuretics, loop diuretics, and your glipizide. Exercise caution in patients with renal impairment. They may cause significant hemolysis if prescribed to a patient with a G6PD deficiency. In patients with renal impairment, a decreased dosage by up to 50%, and if creatinine clearance falls below 15 ml, discontinue the drug. Trimethoprim is contraindicated in patients who have a folate deficiency, so giving TMP-SMC, it may be important to assess for megaloblastic anemia. This type of anemia is again characterized by the erythrocytes that have a larger than normal size. Metabolism-related interactions. Sulfonamides can intensify the effects of Coumadin, dilantin, and glipizide. When combined with sulfonamides, these drugs may require a reduction in dose. Which brings us to ongoing monitoring and interventions. Hypersensitivity reactions. Sulfonamides can reduce severe hypersensitivity reactions, including Stevens-Johnson syndrome. Assess for early signs of hypersensitivity reaction. Photosensitivity. Reactions may also occur, so observe for evidence of sunburns and reinforce teaching as necessary. Hematologic effects. Sulfonamides can cause hemolytic anemia and other blood dyscrasias. Observe patients for signs of hemolysis. When sulfonamide therapy is prolonged, periodic blood cell counts should be made. Renal damage. Deposition of sulfonamide crystals can injure the kidneys. To minimize crystalluria, it is necessary to maintain hydration sufficient to produce a daily urine flow of a minimum of 1200 ml in adults. Therefore, it's important to ensure that the patient is both able and willing to consume adequate fluid if the drug will be prescribed for other than topical use. Metabolism-related interactions. Sulfonamides can intensify the effects of Coumadin, dilantin, and glipizide, so it's important to monitor for increased effects of these drugs and making dosage adjustments accordingly. Cross-hypersensitivity. People who are hypersensitive to sulfonamide antibiotics may be hypersensitive to chemically related drugs. Again, thiazide diuretics, loop diuretics, and glipizide, as well as to some penicillins and other drugs that induce allergic reactions. So make sure you are monitoring for early evidence of a reaction and select a different drug for management as needed. Finally, some prescribing and monitoring consideration for trimethoprim. Its assessment, initial treatment is for uncomplicated UTIs, again caused by E. coli or other susceptible organisms. By identifying our high-risk patients, trimethoprim is contraindicated in patients with a folate deficiency. When possible, the drug should be avoided during pregnancy and lactation, and patients with renal dysfunction require a reduced dose. And our ongoing monitoring and intervention. Hematologic effects. Trimethoprim can cause blood dyscrasias by exacerbating pre-existing folic acid deficiency. Avoid trimethoprim when folate deficiency is likely. Complete blood counts should be performed. If a significant reduction in counts is observed, discontinue trimethoprim. Normal hematopoiesis can be restored again with a medication of leucovirin. And lastly, hyperkalemia. Trimethoprim can cause hyperkalemia, especially in patients who are taking high doses, patients who have renal impairments, or patients who are either on an ACE or an ARB, potassium-sparing diuretics, aldosterone antagonists, or simply potassium supplements. Risk again needs to be reduced by checking potassium levels every 4 days after starting treatment and by exercising caution in patients who are taking other drugs that may elevate potassium levels. And that concludes our chapter here for today. As always, I thank you for listening, and I'll see you at the next chapter. Take care, and goodbye.